Sevgili katılımcılarımız, bu akşam aramızda çok kıymetli akademisyenlerimiz var. İşbirliği içinde olduğumuz Johns Hopkins Tıp Fakültesinden değerli akademisyenler bizlerle Covid-19 tecrübelerini, Johns Hopkins'teki tecrübelerini paylaşıyor olacaklar. İlk önce sözü Tıp Fakültesi Dekan Yardımcımız Profesör Doktor Roy Ziegelstein'e vereceğim. O bu süreç içinde Tıp Fakültesindeki eğitimle ilgili olarak nasıl değişiklikler yaptıklarını bizle paylaştıktan sonra iki tane klinisyenimiz bizlerle hem acil ortamında hem de enfeksiyon hastalıkları anlamında nasıl hastalarını yönettiler bizlerle paylaşıyor olacaklar. İzin verirseniz şimdi Roy'a seslenmek istiyorum. Hi Roy, it's nice to have you with us during this COVID pandemic. I'm well aware that you were as busy as our university, Bezmalem University Hospital, and you had to deal with many COVID-19 patients, and everything has changed. And as we were discussing, we're not back to normal. We are trying to go back to the new normal, but we're very anxious to hear about your experiences with COVID-19 in terms of medical education and also how you treated your patients, or what was your strategy to deal with all these coming in new patients and the healthcare system in your community, actually. So we're once more happy and grateful for you for sparing your time and being with us during your day, but tonight, actually. So please go ahead, and the podium is yours. Thank you very much.
Thank you. Thank you very much. It's a pleasure for me to speak to all of you from a distance like this. Sorry I'm not there. And also sorry that I can't speak to you in Turkish, but maybe next time. I'm going to share something with you. I'm the Vice Dean for Education at Johns Hopkins School of Medicine. And I'm going to be sharing with you the effect that COVID-19 has had on our medical education. And then following me at the midpoint, we'll turn things over to Drs. Maragakis and Kalin, who will talk to you about the COVID-19 epidemic and its effect on our health system. So I'm going to share my screen, and can you see my screen right now? Yes?
Yes. Okay. Yes, we can. Thank you.
Okay, so I will occasionally go to some videos as well so that you can see some of the things that we've done. So first of all, I want to remind people or let them know that in the School of Medicine at Johns Hopkins, we have about 4,000 different students and trainees, medical students, PhD students in biomedical science, master's students, residents, clinical fellows, and postdoctoral research fellows. Remember that in the United States, medical school is a graduate program, so everyone here has already finished university or college. Of the 4,000 trainees, there are about 500 students that are in our 4-year medical school curriculum, or MD curriculum, and that's the group that I'm going to focus on here. COVID-19 affected the experience for all the different types of these 4,000 learners in a very different way. And even within the MD group alone, it affected the experience for each year of the 4-year program in very different ways. So for our first and second year medical students, when the COVID-19 pandemic hit Baltimore around the same time as Istanbul, it was March, and there were a variety of different things happening in the curriculum. All of those things had to be converted to online. So we did not stop our medical school curriculum at all, but within days, we transitioned our in-person teaching for the pre-clerkship students. Pre-clerkship means before the clinical rotations, so the first and second year students. We transitioned it to online. This took an extraordinary amount of time and effort for the faculty to do, but I'm going to show you, and also they created 29 new online electives. I'm going to show you one a video that I think will highlight some of the work that was done. I'm going to stop sharing, and then I'm going to share again. I hope that that this works. Give me one moment to make sure that I can get it right. So I don't know if everyone, can you see my screen, first of all?
No, Roy.
No, okay,
Yes.
hold on one moment. Thank you. I will do it right now. Now you can, correct?
Yes.
Yes.
So I don't know how many of you are physicians on the line, maybe everyone. But I will say that when I went to medical school, I would say that neuroanatomy and brain dissection in particular, I don't think I learned it very well. I learned it in 2 dimensions. I learned it in lecture. So I memorized, as everybody else did, about the third ventricle, the lateral ventricles, how they were connected, what formed the floor of this ventricle and the roof of this ventricle. But I never really could imagine it in 3 dimensions because I had to learn it from a book, a 2-dimensional atlas of anatomy. I will show you what our faculty did. They actually went to the brain dissection laboratory and created these videos. So I'm going to share this. I'm going to fast forward a little bit. So I'm going to stop sharing my screen and go back. The purpose of, can you see my screen again with the slides?
Yes.
Yes.
The purpose of that was not to make you neuroanatomists, but actually to show you the kind of quality video online material. And the entire neurosciences course and many other courses were converted really in a matter of days to weeks to online. And
Yes.
the purpose of that was not. And I will say that much of the curriculum, I believe, was of higher quality, certainly than when I went to medical school. So I want to mention that online education does not mean a reduction in quality or teaching experience for our learners. Our 3rd-year medical students, they were thinking about their specialty choice. What do they want to do after medical school? They were thinking about scheduling their advanced clerkships, their sub-internships, and they were even thinking about beginning to plan their residency application. And then, unfortunately, all clerkships, sub-internships, and in-person clinical experiences had to be suspended in March. So this was a very big change for our clinical teaching. The students were also thinking about doing away electives at other medical schools in the United States and preparing for their interviews for residency. And then something happened. All away electives were canceled. In fact, in the United States, there are no away electives for the whole year. All residency interviews are now going to be virtual across the United States for the entire year. So really COVID has caused dramatic changes in the way that we do things for our 3rd and 4th year medical students. But I don't want you to think that this has all been bad for the clinical rotations either. Again, our faculty have adapted in really tremendous short order. And in fact, some of the things that they have done have gotten national attention in the United States. So it turns out that in addition to transitioning much of the curriculum online, many of the clinical experiences became telemedicine experiences. Lee Goodell, who's a faculty member in anesthesiology and critical care medicine, he actually created a way to bring students into the intensive care unit, even caring for COVID patients, without actually having the students there. So here's what the AAMC, which is one of our major academic medical institutions in the United States, what they said is no classrooms, no clinics, medical education during a pandemic. And they featured Dr. Goodell. They said, before Lee Goodell treats patients in the surgical intensive care unit at Johns Hopkins Medicine, he dons gloves, a protective gown, and a negative air pressure hood that helps dispel pathogens. These days, he also puts on another essential piece of equipment, headgear that holds a cell phone to his forehead so remote students can continue learning during the COVID-19 pandemic. Thanks to the contraption, students can tune in via their computers or iPads as Hopkins educators narrate the unfolding medical process, and they can shoot over any key questions through a live online chat function. So here's a picture of Dr. Goodell wearing his personal protective equipment, but also fitted with a camera that allows the students to participate in rounds virtually. Our 4th year students, so these are our senior most students, they were looking forward to match day. That's when they find out where they're going to be residents. Also to our convocation celebration, that's their graduation ceremony that they look forward to for many years. But unfortunately, neither of these two things could occur in person. So we had to move them to virtual. And this is a picture of the website for our 2020 Johns Hopkins School of Medicine convocation ceremony. Basically, every component of the traditional ceremony was converted to online. Here you see the different components lasting each about 4 minutes. These are some of the speeches, comments by our invited speaker, announcement of awards, conferral of degrees, and so forth. This is our program for the convocation. And I want to emphasize to you that we did as much as we could to preserve the fantastic and wonderful atmosphere that one sees at a traditional in-person graduation ceremony. I'm going to show you now a video from, if you'll give me a minute to stop sharing. Yeah, I stopped share, and then I'm going to share my screen again, and I'm going to show you, let's see, I hope this is it. No, 1 minute. Give me 1 minute. Apologize for my challenged nature. 1 second. I'm going to oh, there it is. I just need you to okay. Can you see that?
Yes, we can now.
Okay, great. I'm going to fast forward a little bit to show you the reading of the Hippocratic Oath, the signature moment of convocation.
Görüntünü açayım mı?
So thank you for bearing with me with the technical part of the of this. So I hope that gives you some sense of can you see this screen?
Yes.
Okay, I hope this gives you some sense of what we were able to accomplish to actually even recreate the reading of the Hippocratic Oath in an online format. So now I want to shift a little bit to what we're doing now. You know, the hospital doesn't usually look like this. The corridors, the hallways are not usually empty. They usually look something like this, I'm sure at Besmi-Allem and also in Baltimore at Johns Hopkins. And so we need to figure how can we bring students back to the clinical environment that's very fast-paced and busy with the difficulties for social distancing and so forth. So we established certain guiding principles in terms of health and safety, not only of the students, but also of the healthcare teams, and also thinking about the high standards that we have for their education and student experience. We decided to adopt a phased approach. We thought that any content that can be delivered online should be delivered online. And then we recognized that we would move from a phase where we had no students on the clinical environment to low, phase 1, medium, and high density in-person activities. We are basically in phase 1 now. And importantly, we have had to coordinate our plans in a way that we never did before with the entire Johns Hopkins University, with our state, with our peer institutions, with our accrediting bodies like the LCME, with our national organizations like the AAMC, our specialty organizations, other learners in the environment. We have social work students, physical therapy students, dietitians, and so forth, and with guidelines from the Centers for Disease Control. Here is an example of a guideline that we have to follow. This was issued in mid-March by the AAMC about medical students. So it was constant monitoring of guidelines from national organizations. This is a guideline from our university in terms of research return to campus. So we also had to coordinate our activities with the entire university. This is a dashboard that is developed by the AAMC with all 155 schools in the United States contributing data to the dashboard that again helped me to coordinate the activities at Hopkins. There were also weekly calls. There are still weekly calls with the AAMC. Again, the major considerations were the health and safety of our students and trainees, that anything that we could teach remotely, we would. We had to very carefully monitor the course of the pandemic, and Drs. Kalin and Maragakis, who are going to speak to you soon, have been phenomenal in that regard. We had to make sure that we could access personal protective equipment or PPE for our learners. And then again, we had to coordinate with other programs and their leadership. We had to train all of our students in the importance of hand hygiene, social distancing, donning and doffing masks. We had to think about the changes in the clinical learning opportunities. For example, many of our physicians were redeployed to take care of COVID-19 patients, and there was a time when they would not have been ready to accept students. We had to make sure that there was adequate supervision of our students. Again, if faculty and residents and fellows are taking care of COVID-19 patients, it would be very difficult for them to supervise our students. We had to think about our students who might be on immunosuppressive treatment or pregnant or very anxious and how to deal with that. We had to make sure that they understood the importance of being aware of symptoms and self-monitor for symptoms. And then we had to think about when and under what circumstances testing of students might be done. We developed what you might call in the airline industry a pre-flight checklist, but we developed it for our students and trainees. It really related to their professionalism, that we called on them to monitor themselves for symptoms, If they had close contact with somebody who had been diagnosed, they needed to let us know. If they've been notified by a public health official that they've been potentially exposed, they need to let us know. Or if they have not been able to adhere to masking and social distancing in their daily lives. We actually created a series of videos, again, with the help of Dr. Maragakis, Dr. Kalin, and others, on hand hygiene, universal masking, social distancing. I'm not going to show you the video now, but these videos are very informative in terms of how to clean the PPE, reuse and conserve the PPE, put on the PPE, take off the PPE, and so forth. We have a website that was developed in part by Dr. Maragakis and Dr. Kalin on PPE resources and conservation that we shared with our students. There are a variety of different published material that we shared with them. This is an article from the New England Journal, which has videos on PPE that you see here. We showed them a series of infographics we shared with them on what to do with patients under investigation or patients undergoing asymptomatic testing. Of note, we have not involved our students in the care of patients who are known to be infected by COVID-19 or who are suspected of being infected. Again, these are a series of infographics on what type of PPE to wear under what conditions, how to go about airborne and contact precautions with and without eye protection. And then on May 26th, 2020, our rising fourth year started this phased reintroduction of our students, beginning with the fourth years on May 26th for their required sub-internships. And then our rising third year students will return on July 6th, 2020. Again, we made sure that they were trained in PPE, that we had PPE packs, masks and face shields distributed to them. Certain rotations like anesthesiology, they needed to be fit tested for N95 masks. And again, we made sure that our timing of things was similar to other peer institutions and medical schools across the United States. We also looked at all of our teaching spaces with the help of the university, and we mapped out the capacity of all of our teaching spaces in a COVID-19 world of physical distancing. And what we found is that, as I'm sure you found at Besmi-Allem, that allowing for the appropriate physical distancing, typically our lecture spaces were cut down from 100% capacity to about 15, maybe 20% capacity at most. And this severely restricts what we're able to teach in lecture format in person. I will close with the last slide by saying that this slide is familiar to most medical educators in the United States and hopefully across the world. It is the 1910 Flexner Report on medical education in the United States and Canada. That report actually specifically highlights Johns Hopkins, a model in 1910, 110 years ago, for medical training in the United States and Canada. I think actually that while all of us feel very sad about COVID-19, it's been a terrible experience, I'm sure, in Istanbul and in Baltimore, in Turkey and the United States, at Besmi-Allem and at Johns Hopkins. And yet at the same time, I think it has created opportunities for us to really think about, reimagine how we educate and teach our medical students. And I believe that this is a second revolution in medical education in the United States. And I hope that Johns Hopkins is able to lead this revolution as it did 110 years ago. So I'm going to stop sharing. I don't know if Dr. Kalin, yes, I see Dr. Kalin is here. I will introduce Dr. Kalin. I don't know if Dr. Maragakis is also here. I'm looking quickly through. Let me introduce Dr. Kalin. So Dr. Kalin is one of the most esteemed faculty at Johns Hopkins. He is our department director for emergency medicine. and he is the director of the Office of Critical Event Preparedness and Response, and the director of the Center for the Study of Preparedness and Catastrophic Event Response. It's a very long title for a really wonderful faculty member, and he will share his screen and teach you about how COVID-19 has affected Johns Hopkins and health in the United States.
Thank you so much, Roy, for that wonderful introduction. I hope I can live up to just a little bit of it. Are you seeing my screen at this point?
Yes.
And everybody can hear me reasonably well?
Yes, we can hear you.
Yes,
Thank
we
you.
can.
Wonderful, thank you. And Dr. Ziegelstein, if you can make sure I stay on time, just kick me or give me some kind of sign. So I'm going to talk about a specific issue, modeling for COVID and pandemics that informs how we try to prepare. As Dr. Ziegelstein mentioned, I had the Johns Hopkins Office of Critical Event Preparedness and Response, which is responsible broadly for overseeing and coordinating the entire enterprise and all of our entities' response, and to make sure it's reasonably coherent and that the policies are synergistic. We do, as a group, a lot of modeling for different types of disasters, but it's infectious diseases that I want to talk about, and particularly how we go about modeling for surge. This is agent-based modeling by one of our previous faculty, Josh Epstein. There's literally almost everybody in the world, 6.5 to 7 billion people modeled out in this. And this is just one platform that allows us to play with a number of scenarios as to how infection spread, looking at things like travel and vaccinations and school closings. I'm just going to quickly whip through this because I mostly want to just show you some of the agent-based modeling capability that we have. And we can layer on top of this or within it models that look at the implications of how rapidly things spread via the modern day travel, and right down to a series of individual cities looking at susceptible, exposed, infected, and recovering, and so forth, and map out the expected curves for a series of different cities. So then we do this similar type of exercise for influenza-like pandemics. I can show this in a number of ways, but this particular one we did, again, 300 some odd million people mapped out, showing the spread of infection in the United States, looking at the way people interact and travel and schools and so forth. In this one, everything is wide open. And you could see in some sparsely affected areas, there's still nobody infected, even though other places, people are beginning to recover. And again, in the interest of time, I'll just speed this up. Eventually, there's herd immunity, and people who've died have died, but everyone else is hopefully immune, at least until the next time. So then we take these models, and let me say parenthetically, as we all know, models are only as good as the input that we put into it. But so here we're looking at that base case that I showed you and the impact of travel restrictions, vaccinations, and school closures, and I'll run them these simultaneously. The base case is what it is. Notice already in the vaccination group, a fair amount of spread with recovery a little bit faster because we're vaccinating people. But look how slow the travel restriction is. But if I allowed this to play out over time, we would see that eventually it looks the same as all of these. It just takes an awful lot longer. And so these are the type of predictive curves that this amounts to. So here's a typical influenza that people, or influenza-like illness that so far people do not have immunity to in the US, depending on a number of issues, but let's say roughly about 60% need to be infected for there to be herd immunity. And you can see kind of the expected curves for the different type of things. School closings in the kind of infections that impact children are in fact helpful, but only if you do it fairly early. If you do it too late, it's not known to be super helpful. But look at this travel. If you restrict travel, you got your hump, you restricted travel, you get another one. Eventually, the breakouts continue because you can't perfectly, at least in the United States, you can't perfectly lock down a country like this. And even vaccination, without complete vaccinating the population, as you might not be able to do once an outbreak occurs, still has a fairly profound impact. Notice that the scale I'm using here, unfortunately, is smaller. So if I was comparing it to these others, this would be a very much smaller hump. But overall, since you didn't vaccinate everybody, it still takes some time to get through society. Here's one we did with, I believe this was H1N1, looking at school closures with early vaccination, finding that those two together are the most effective. Now, I want you to sort of notice the shape of this initial curve. There's a lot of cases and everything sort of looks like it's fine, but new cases still come up at an even higher rate than before. We're in one of these kind of lulls right now in the United States and in many other countries. But we've only seen infections, depending on the area, between 1% and 2%, and maybe in New York, some around 14, 18%, I've heard. So we take these data and try and understand what's happening in our state so that we can make plans directly at a hospital level. And we model out, this is Ailey Klein's work, who is a public health expert, but is also a modeler in our department. And he's modeled out a number of scenarios. I'm only going to show two of them to you. One is when you put restrictions on, it could tamp down the impact. But we're at this point now where we're lifting restrictions, but we still want people to take precautions. But we're assuming here that in one scenario that maybe only 50% reduction in social distancing, which is fairly high. And then one that says, oh, there's some reduction, but most people are still more or less masking and hand hygiene and social distance, and restaurants and everything are following precautions. And you can see the difference. But we're anticipating a second big hump one way or another. Things in some states in the US are lifting very quickly, and we're starting to see a rise already for those states, and hopefully we're one of them, although it's not clear that will remain so. The next hump will come when schools open, and it'll be a lower hump, but it's still a significant one compared to what we thought we were experiencing. So in our models, in the old models, we didn't have this ability, but now we have the ability to track cell phones as a way to determine how close people are to getting to each other. So we map out every jurisdiction in our state, all the counties, to get a sense of whether people are coming back to their full level of interactions. Doesn't necessarily mean they're not wearing masks and keeping social distancing, but they can't be keeping a lot. The places that have a lot of interaction are the ones that are less likely to follow precautions. So these very individual data right down to the level of a county are fed into our model, because we have 5 hospitals in our system here in Maryland. Actually, one of them is just below the state line in Washington, D.C. And this maps out the expectation of actual hospital beds that we would need to take care of the sick people. And we can differentiate this out for ICU and whatnot. But so we experienced this hump in early May. And if you add up the burden of all of our 5 hospitals, we hit a peak of a little over 300 beds. You can see that we are very worried that there's going to be a much, much bigger surge. And we felt like we were already at pretty full capacity. Now, this is truly alarming if this comes to pass. This is that things open up very quickly and people, many people don't follow social distancing, and we have a very overwhelming curve. These are each individual hospitals. You can see if this was actually true and you added this up, we would be in very big trouble. But this kind of modeling has been verified that these kind of patterns are seen. If you look at some of the curves for the 1918 pandemic, they do look like this. This is in Alberta, Canada for H1N1, which obviously behaves somewhat differently than coronavirus in that H1N1 targeted young people. But it shows the impact of schools. And so initially you can have some impact here, but a second bigger hump is expected. We do other types of health system modeling. This is a program that we have. If this is recorded, then you can have this, or email me. I'll send you the link where you can take either your entire health system or a specific hospital, or only your ICUs, or even just a specific floor, to get a sense of how much space you need to create for the number of patients that you believe are coming in. And so you can play with this in your, if you want to go to that particular link. And I wanted to bring attention, one of the things that we've modeled in the past, we haven't invoked this yet, is this concept of reverse triage, where patients at low risk, you'd normally keep them in the hospital, but you're hoping to be able to send them to a safe place for relatively early discharge. And you can free up, these are 3 of our hospitals, one's a community, one's a teaching affiliate, and the other's Johns Hopkins. You can see you can free up a significant amount of space if you have a safe place for low risk patients to go home. The last thing I want to talk about is this curve, and then if Dr. Maragakis is on, I'll turn it over to her. There's a very famous curve, of course. It's the coronavirus curve. And one of the reasons we're all going nuts putting mitigation in place is that when the health system is overwhelmed, then people who might otherwise be saved, who are very, very sick, might end up dying needlessly. So the idea is that we would prevent preventable deaths. So what we're hoping to do is flatten this curve. Now, theoretically, the area under the curve, meaning the total number of people without any intervention that ultimately become infected till you reach herd immunity, is the same whether it's this curve, or you flatten it even further because you have other patients that you might want to be able to see. And this is what we're trying to do now. We're trying to get back to a concept called new normal, where we can take care of other patients. So there are 4 reasons to try and flatten this curve. The one I mentioned, to prevent preventable deaths, and to buy time to buy a vaccine, which would artificially induce herd immunity into the population, and hopefully faster. Buy time for treatments that are successful, that doesn't decrease the total number of infections, but it helps keep people well and hopefully save even more lives. And just on the off chance, this is a fairly stable virus, but just so it may not mutate the way other coronaviruses and influenza-like viruses mutate, but we'll see if it shows any type of seasonality or cyclical degradation of its virulence. So I'm going to leave you with this last thought of what we're really trying to do now. There really are three curves. So there's this coronavirus curve, but we actually need room for emergencies, and people have been afraid to come into the hospital with their emergencies, but we need some room for that for sure. And then we need room for people who have comorbid conditions and chronic health problems that if they don't get attention, they're definitely going to deteriorate and potentially die. So as we think of hospital capacity, it's not just the coronavirus curve that we have to consider, but getting back to being able to provide basic services for all our patients. So I'm going to stop there. And I don't know at what point there may or may not be questions, but Dr. Ziegelstein, thank you so much for inviting me to and giving me this opportunity to talk about how we're approaching surge capacity in our system.
Thank you very much, Gabe. That was really terrific. I'm going to, we can save questions maybe till the end. I'm going to turn things over to Dr. Maragakis, who's our Senior Director for Infection Prevention at Johns Hopkins, and she's even been on television a lot lately as she advises the state and the public. So Lisa, it's all yours.
Thank you, Roy, and thank you, everyone. It's really an honor to be part of this today and to speak to you. Just to note that being on TV was never one of my goals, so I don't know that that's anything good about the pandemic. But today I thought I would talk with you about some of our preparations in Johns Hopkins Medicine and sort of walk through the timeline of our response and some of the key aspects of it. And hopefully in the question and answer, we can have a dialogue about some of those strategies. And I've certainly heard wonderful things about the remarkable job that you all have done and the great success that you've had so far. So we would like to learn from you as well about that. So our preparations really began in earnest in January, at least within the infection prevention department, my team, as well as working across our health system with our emergency management colleagues and working through their infrastructure that they've built through our health system. And I'll start by just saying a word about that because I feel like it is such an important part of preparedness activity to have some sort of structure pre-existing an emergency. And our emergency management colleagues have really built that throughout all of our organizations, our departments, so that we had lines of communication and clear roles and responsibilities and some relationships and infrastructure that was built for responding to an emergency. Of course, we could not have anticipated the vast scale of this challenge, but it did still serve us well. And so one of the first things that we did in early January was to take our pandemic respiratory virus planning off the shelf, dust it off and really examine it to see, in light of the challenge that we knew that was coming, how prepared we felt we were and where we needed to bolster the planning and add more details around it. One major part that we really had to put a large amount of attention to was the fact that there is a question about whether this virus can be transmitted by the airborne route, in addition to large droplets and to contact with infected surfaces or secretions. And so because of that, and because we communicated very early on with colleagues at the United States Centers for Disease Control and Prevention, who assured us that they were not going to change that part of the recommendation, that if possible, airborne precautions and respiratory isolation should be utilized. And we knew that that was going to present a significant challenge over and above anything that we had planned for in our pandemic respiratory virus plans, which were mostly based upon droplet spread of a respiratory virus. We were very fortunate that many of our buildings had airborne respiratory isolation in mind when we designed and constructed the buildings. We had never utilized this feature on a unit level. Of course, like many modern hospitals around the world, we had airborne isolation capability in airborne isolation rooms, but they were scattered across our hospitals, generally no more than 2 or 4 rooms with airborne isolation characteristics on each unit. And yet for this, we knew that we would likely be presented with large numbers of patients and wanted to cohort them into respiratory isolation units together. And so really this led to a unique approach that we had not taken previously in our health system, and that was to cohort patients with a certain disease, in this case COVID-19, not only in certain units, but also in certain hospitals within our health system. And so in the early days, when patients were first being admitted to or presenting to any of our hospitals, we actively transported them to the Johns Hopkins Hospital, where we had the best pre-existing air handling isolation capabilities. So that's one example of the kinds of plans that we needed to put in place in January. In addition, we began in earnest to acquire personal protective equipment, and particularly respirators, recognizing, again, we could not have anticipated the degree to which we would be challenged with the supply chain issues that later presented themselves. But we did know that that we would be better positioned if we had reusable respirators, such as powered air purifying respirators or PAPRs, or even we acquired some of the face mask respirators as well, that are typically not used in healthcare, at least in this country, but augmented our ability to have reusable respiratory protection for our workforce. And so after putting all these plans in place through February, we decided that we would stand down on a watch level. And unfortunately, that only lasted for about a week and a half before the first cases were detected in the United States. And our whole health system stood up a unified incident command across Johns Hopkins Medicine to coordinate our response. We have admitted to the hospital and the intensive care unit over 1,800 patients now. I mentioned that early phase of our response where we were transporting patients, no matter where they presented in our health system, to the Johns Hopkins Hospital. Quickly we exceeded the capacity that we had planned for in those respiratory isolation units. And thankfully, though, that initial planning and strategy allowed us time to work with our facilities department, alter the air handling, the HVAC systems, and construct anterooms and make physical plant changes at our other affiliated hospitals, so that each hospital throughout our health system then had the capability to safely care for patients in these respiratory isolation units. And that has been our strategy ever since. As I said, we've cared for more than 1,800 patients now. And at the peak, which was in early May, we had at one point 300 patients in our health system at one time. That has thankfully reduced. The trends are going in the right direction in our Baltimore and Washington, D.C., Maryland area. We do have one children's hospital that is in Florida, and the numbers in Florida are going in the wrong direction. They are experiencing a surge after opening beaches and really quite a rapid reopening across the state, and they're seeing a resurgence of their numbers. But so far in the Maryland area, we have had favorable trends, and we are now under 200 patients. I think it's actually closer to 150 today in our health system. So we are cautiously optimistic about that. Unfortunately, we have seen, while not so rapid, but we have seen a steady opening and reopening of businesses and, of course, protest activity in our streets. And so we know that between that and the good weather and people reducing their social distancing, that we anticipate a second surge or increases in the days to come. I've talked a little bit about the facilities changes that we made, and it really was remarkable to me that our facilities teams were able to retrofit our heating, ventilation, and air conditioning systems in such a way and utilize HEPA filters to convert almost any space into a negative pressure isolation area. And we're very grateful to them for doing that. Between that and the personal protective equipment strategies that I outlined, particularly the reusable respirators, but also a policy of universal masking for anyone who enters our facilities, and wearing a mask and a face shield for all patient care, not just for those who are known to have or suspected to have COVID-19, I think has really provided the environmental controls and the personal protective equipment to keep our staff safe. We have had several hundred of our employees test positive for COVID-19, but I will say that we investigate each of those, and the large, vast majority of them have community exposures, often in their own households, sometimes in clusters of employees in our facilities. And we actually believe that one of the safest things that our providers can do is put on their personal protective equipment and serve on one of the COVID-19 inpatient units. Where we see more risk is in the social interactions in non-clinical settings, either in the community, but also in our own facilities. And one of the biggest challenges is break rooms, where people remove their masks in order to eat and drink. And these are often small areas, and people forget about social distancing. And we have had a few clusters due to that. But all in all, we believe we've been very successful in protecting our workforce. We have strict visitor limitations in our health system, and so really do not allow visitors. And this has been extremely hard on our patients and their families, and also our employees. It's a very emotional issue to not be able to allow families to be together when they're facing what may be one of the biggest challenges of their lives. And we do make exceptions for that. If it appears that someone is dying, of course, we do allow family to be at their bedside. And we have a variety of other exceptions, but we've really minimized it for everyone's safety. I wanted to say a word about our pathology colleagues in microbiology. I'm sure that everyone has heard the news reports of the challenges with rolling out testing in the United States. And this is a very complex issue that I'm not sure any of us really understand all of the things that have caused the problem, but it certainly has been a problem, and one without national leadership to really solve the barriers that exist to implementing widespread testing. But here at Johns Hopkins Medicine, we're extremely fortunate because our own colleagues developed an in-house test and was one of the first to do so and to get approval from our federal agencies to use that test for clinical diagnosis of patients. And so from the earliest days, we have had in-house testing capacity. And since that time, they have validated and brought online 8 additional platforms to test. And why do we need so many? Well, it's really, again, back to that supply chain challenge that I mentioned earlier. It's unbelievable to me that in addition to facing one of the largest infectious disease threat of our lifetimes, that in addition to facing that threat, we also are doing so with shortages of personal protective equipment and very basic things like lab reagents, hand sanitizer, and disinfectants. And so this has affected the testing capacity. But as I said, our pathology colleagues have brought together all these platforms and used them kind of in a patchwork so that they've been able to increase the testing capacity currently to 1,200 tests a day. And they say that they will shortly be at 2,400 tests per day, which will be fantastic. They also have brought stat testing online, and so we have carefully utilized that scarce resource for the patients for whom that we need a very, very rapid answer. We also have some point of care testing available. And so I guess the other thing that I would mention is just the redesign of healthcare delivery that has been critical to our response. And that involves things like telemedicine, so that we can reduce the exposure to our own staff and to the patients while providing them with the information and the care that they need if they're not in need of inpatient care or emergency room care. It also has helped to decrease the surge that we've experienced in our emergency department and inpatient locations. So telemedicine, the implementation of all kinds of new work streams to offer testing safely to patients, as well as really setting up separate streams within our entire healthcare system for caring for patients with COVID and also those without COVID. We have seen a resurgence, initially a very sharp reduction in the number of patients presenting to our facilities without COVID-19, with the normal things, a medical condition, provide care, and they are now returning. And so currently we're in a challenge of staffing above all else, trying to see how we can provide the care we usually provide, and in addition, maintain care for those who are suffering from COVID-19. So for the foreseeable future, we think this will be the challenge that we are asked to face. And we are beginning electives, and turn it back to you, Roy.
Rameza, did you want to, thank you, by the way, to everyone for allowing us the opportunity to present what's going on at Hopkins with the group. Are there
I'll take a first shot based on what I presented. So it seems like you've done a really terrific job in helping contain the pandemic, and yet there's a world around you, and at this point there's no vaccine. So a huge number of people in the population remain susceptible. And if you can keep up this level of containment and mitigation until a vaccine or some other natural intervention comes about, most people are predicting that one way or another, a certain percentage of the population will get infected. A number that you frequently see is 60%, and it just has to do with a formula with susceptible and infectivity of the virus. Some people think it's even higher. So if you can keep up what you're doing to protect the population until there's either a natural or a vaccine or treatments that lessen the impact, eventually it will go through the population. I don't know, Lisa, if you agree with that or not, but broadly speaking, I think that's the prediction.
I do. I think that's very well said, Gabe. And I have a similar feeling that you've seen tremendous success. I think that it takes a proactive approach, which you have done, and then it takes patience. And I fear that what we're seeing here in the United States is a wearing thin of our patience. And so the reopening, and again, as Gabe said, it varies place to place. And so it's a challenge, I think, for all of us really around the world to can do a continual risk assessment to keep it front of mind and to continue to buy the time that we need to develop a vaccine and therapies.
You're on mute, Rameza.
Do you think I can ask another question? Thank you for the answers. While this is interesting, do you think COVID-19 proved modern medicine illusion was not robust and we need more robust medicine post-COVID-19?
Say a little bit more what you mean by robots. You mean like...
Well, if I had asked the question, I would have more to it, but it's one of the questions that I have received.
Someone else's.
This is a challenging question, that's for sure, but let's think about it. But the other question that I had received was, what do you think about the next term? As we follow the American universities or some universities in the UK postponing the term till the beginning of 2021, January. So what you're actually thinking, I saw that you're thinking about having your students back in July 3rd. Do you think it's going to be actually a reality, or should we think postponing having students without looking at the surge that Dr. Kellen showed us, actually potential curves actually, or surges?
So that's an easier question to answer.
Yeah.
I'll just say that it's a great question. I think that I'm reasonably confident about July 6th. The second part of the question, though, is much more difficult, which is when our students would come back. We call it the fall, the autumn, but it's actually they come back in August. And I think I'm fairly confident about August, but it's a little later than that. We've had to really reconfigure our rooms, and I'm worried because I get to hear Dr. Kalin almost every day. So he worries me. Just when I start to feel okay, he makes me nervous again. And I think that it's hard to ignore the possibility that there will be a second surge in Istanbul, in Baltimore, across the world. And so I think what we are trying to do is hope that we will be able to do at least some of our curriculum in person, because we believe that there are certain things that are better taught in person, and then prepare as if there will be some parts that we won't be able to do, and prepare to have things by video conferencing. It's a big job to convert everything to video conferencing in short order. So that's what keeps me up at night. Rameza said when I joined the phone, she said, "You look terrible. You look so tired." And now you know why.
Come on, I
think you look great, Roy. Better than ever.
I do. I do too.
Thank you.
I would say, so both Lisa and I remain clinically active. So some of these issues are very real to us. I'm in the emergency department, so it's pretty front line. Lisa's obviously infectious diseases, so she's seeing patients who are infected. And so this is very real. I'm almost petrified by the fact that all my senior residents are graduating, and a bunch of, that's not the right term, but a new group of medical students and new interns. And the interns were medical students just a few days ago, but many of them haven't been near a patient now in 3-4 months. And they're going to show up on a rotation like ours. And we used to do a lot of hands-on training even before they got to see a real patient. And I'm just worried about the lack of experience even greater in this era of COVID, and then the potential to hit a surge with a very untrained, inexperienced group. That petrifies me. But I would say parenthetically, and Roy, you frequently told us, the medical students want to be active clinically. They want to be on the team. They train for this. They feel we put in a lot of effort in their training. They want to be on the medical teams.
Yeah, and the faculty want the students to be there. You know, Khalil, whom you know very well, Rameza, he is constantly calling and emailing me and saying, crying, where are the students? I want to work with the students. There he is.
It's absolutely true.
You know, I was going to comment, I'm not sure about the earlier question about robots, but I wonder if it had something to do with telemedicine and, you know, the vast changes that we have seen in healthcare delivery during the response. I think a lot of that is probably here to stay. I think we have learned a lot about when it can be helpful and how to do it better. We need a lot of reforms in the payment models and reimbursement and technology to make it even more effective and viable as a strategy. But you know, I think that we've also seen that it can't replace the clinical in-person care that we provide. And I'm just really amazed by the clinical advances that the teams have made in such a short period of time to learn about this disease and to adapt our care to optimize care of these patients. So I think amazing things have been done that just reinforce the role of traditional medicine.
I want to ask one quick question, last question actually. Do you know your numbers? The patients that you admitted to Johns Hopkins for COVID-19, just, you know, approximate numbers that you took care of?
Lisa, you're probably most up on that. Right?
Sure. Well, it's over 1,800 across our health system. And at any one given time, the highest we had at one time was 300. And now we're down to about 150. But all total, somewhat over 1,800, I think close to 1,900 now.
Okay,
and how many tests have we done, Lisa, all told? How many patients have we tested?
Yeah, we've tested over it's over 40,000. I don't have the exact number, but over 40,000 and close to 5,500 positive.
Right.
Right, thank you. Okay, Roy, I don't seem to have received any more questions. So
no, thank you so much for hosting us and inviting us. This was really great. I think that it helps the spirit of collaboration between our two schools and the great people there at Besmi-Allem, our friends.
we thank you for taking your time during the day. And I know that you're very busy, but we enjoy being with you personally. And that's why I commented about you look tired. I know how you look when you're in Besmi-Allem in Istanbul. So we want you, those who haven't had a chance to visit us, to sit and see how it feels different in Besmi-Allem. And thank you very much for taking your time.
I think, Rameza, it's possible that the Turkish tea is actually the secret. And that maybe this kills the coronavirus. This is what I'm thinking. I still have some. I'm going to try some right now.
please do not discuss that controversial issue, because there are some papers just, if you drink so much cups of tea per day, it might protect you against your COVID-19, which I don't want to discuss currently. So anyway, just
Thank you.
look to stay safe, and thank you for joining us
Thank you.
tonight. And you have a good day, and
You too.
bye to every colleague over there, to our friends in Johns Hopkins. Thank you.
Have a good evening.
Thank you.
Thank you very much.
Pleasure to be on with you.
Bye.
Thank you.
Bye-bye.